Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Today we're focusing on something you, the interventional radiologist, deal with directly. We're looking at Y-90 radioembolization.
Right.
But we're not talking about survival curves today. We're diving into the liver toxicity from Y-90.
Yeah, that's the goal.
We all know Y-90 is a powerful tool, but understanding the liver injury that can follow that syndrome with the jaundice and the ascites, it's the cornerstone of safe practice. Okay, let's unpack this. Specifically, the liver disease induced by radioembolization.
To set the baseline, this is a very distinct clinical entity. It doesn't look like your standard tumor progression in the liver. It usually presents pretty aggressively, maybe 4 to 8 weeks after the procedure.
And what does that presentation look like?
It's defined by two key things. Significant jaundice, we're talking total bilirubin climbing over 3, and the onset of ascites.
Okay, and pathologically?
Pathologically, this is not standard radiation necrosis. It falls squarely into what we call hepatic sinusoidal obstruction syndromes. The hallmark is Veno-Occlusive Disease, or VOD.
That distinction is so important, isn't it? Because when we think of classical radiation-induced liver disease, REILD, we're usually taught to expect anecdotal ascites.
Exactly. The presence of that severe jaundice is the real telltale sign of a systemic sinusoidal injury. And that's what makes this so much more like what's called combined modality-induced liver disease.
The kind you see in bone marrow transplant settings.
Precisely. After high-dose chemo and total body irradiation, both combined modality-induced liver disease and this post-radioembolization syndrome are defined by that severe, often life-threatening jaundice and ascites.
So the mechanism is actually closer to a chemotherapy or systemic toxicity than a traditional radiation burn.
That's a great way to put it.
So what about incidence? I mean, how often should we really be expecting to see this? The literature seems a little all over the place.
It is. It's notoriously hard to pin down because the older studies all use different definitions. You'll see reviews quoting symptomatic incidences anywhere from, 0% all the way up to 31%.
Wow, that's a huge range.
It is, but with modern techniques and better definitions, most current data puts the clinically significant incidence somewhere between 0% and 8%.
That 8% still feels significant given how severe it can be. What about mortality?
Lethal outcomes are reported in that 0% to 5% range. And when it is lethal, it's because that underlying VOD pathology just leads to rapid progressive liver failure.
And the histology backs that up.
Oh, absolutely. In the severe cases, you see extensive sinusoidal congestion, necrosis around the central veins, atrophy, fresh thrombosis. It is textbook VOD.
It's fascinating how much we can pull from analogous fields like hematopoietic stem cell transplantation, HSCT. Since this is the same VOD pathology, what does that tell us?
Well, the HSCT literature really hammers home that severity grading is the key for prognosis. Poor outcomes are almost always in the severe and very severe grades.
So the mandate for the IR is early diagnosis.
And it raises the question of early treatment. Things like defibrotide, which is approved for VOD in the transplant world. Its role here is still being investigated, but it's on the radar.
Okay, let's pivot from the path lab to the angio suite. This is where it gets really actionable. If this is a VOD-like injury, what are we doing in our workflow, in our planning, that's causing this?
The foundational idea here is what's called the combined insult theory. Basically, the complication almost always appears when the liver tissue is already primed by some prior damage.
Cirrhosis.
Cirrhosis, yes, but even more commonly, prior systemic chemotherapy. And then it gets hit with the radiation from the Y-90 spheres.
So if you have a patient who's chemo-naive, or you're just treating a tiny segment of one lobe, the risk is very small.
Pretty much. The complication almost never happened in patients who had no prior chemo or when the treatment was super selective. That prior chemo exposure is the biggest red flag.
I saw some data on that. It was something like 100% of patients who got this complication had prior chemo versus maybe 2/3 of those who didn't.
Exactly. It tells you the injury is synergistic. It's not just 1 + 1 = 2.
And the timing of that chemo is a decision point, right? If you give chemo too soon after the radioembolization, the risk skyrockets.
The data strongly supports a clear 2-month chemotherapy-free interval after a salvage radioembo procedure. You have to give the liver that window to recover from the radiation before you hit it again.
Let's talk about the variables the IR controls directly. Dosimetry, procedure. What's the link to treatment intensity?
It's paramount. specifically the dose relative to the volume you're targeting. This leads to a safety number. Most severe cases happen when the dose went above 0.8 GBq per liter of targeted liver volume.
zero point 0.8 GBq per liter. So that's the hard stop for whole liver treatments.
It really should be. Below that level, the risk drops off a cliff.
What about the extent of the treatment? Whole liver versus just a lobe?
Another major factor, whole liver treatment carries a significantly higher risk. I mean, it makes sense. This is why everyone is pushing towards more and more selective injections. Spare that healthy parenchyma.
And in patients without cirrhosis, you almost never see this after a truly selective treatment.
Correct. It reinforces that idea of sparing healthy tissue whenever you possibly can.
I saw another subtle finding in the sources that was fascinating. Patients who needed a flow redistribution procedure, like coiling off a vessel to an extrahepatic organ.
Yes, they were more likely to develop the complication.
Wait, why would that be an independent risk factor? Is it about the arterial architecture being more complex to begin with? Or something about non-uniform dosing after you change the flow?
It probably signifies a more distorted arterial supply, which might lead to less predictable distribution of the spheres. Or maybe it just tells you that liver is already hemodynamically stressed.
Yeah.
It's a bit of a warning sign.
And beyond the procedure, there were some independent patient predictors, right? Things that make certain people just more vulnerable.
That's right, two main ones, younger age and baseline liver function.
Younger age is counterintuitive.
It is. Specifically, under 55 years old was identified as a risk factor. The sources don't really have a definitive mechanism, but it could be related to a more vigorous inflammatory response to the radiation.
Okay. And baseline liver function is more obvious.
Of course. A higher baseline total bilirubin over 1.05 in non-cirrhotics or 1.2 in patients with cirrhosis was a clear independent predictor. If the liver's already stressed, it just can't take the hit.
This all sounds like a recipe for a change in practice. When centers put all this together, the combined insult theory, the dose limit, the bilirubin cutoffs, what happened to their complication rate?
This is where the data is powerful. By implementing a modified protocol based on all these lessons, the safety improvement was, well, it was dramatic.
How dramatic?
Under their old standard protocol, the incidence of this liver disease was a shocking 22.7%. After the modified protocol, it dropped to 5.4%. And more importantly, severe events grade 3 or higher went from 13.3% all the way down to 2.2%.
That's an incredible reduction in severe harm.
Yeah.
So what were the actual practical changes that got them there?
They focused on 4 pillars. First, just being more conservative with who they treated. They dropped the bilirubin contraindication from 3 down to 2. They just stopped treating the highest risk patients.
Okay, that makes sense.
Second, technique. A mandated increase in using selective, even subselective injections to really maximize sparing normal liver.
Pillar 3 must be dosimetry.
Yep. A general 10 to 20% activity reduction became standard for whole liver treatments, and they cut it even more for the high-risk patients, small liver, cirrhosis, heavy chemo history. They were actively aiming to stay under that 0.8 line.
And the fourth pillar was medical prophylaxis, which speaks again to that VOD connection.
Exactly. They started routine use of concomitant medications, ursodeoxycholic acid, and low-dose steroids like methylprednisolone. The idea is to help stabilize cell membranes and just quiet down that early inflammatory cascade.
Okay, let's talk about the worst case scenario.
Mm-hmm.
A patient develops this despite everything. Their bilirubin is climbing past 20. What does the acute management look like from an IR perspective?
Well, it starts with supportive care, diuretics, but because this is driven by portal hypertension from the VOD, you might need a more aggressive intervention.
Like a TIPS.
Exactly. The sources cited cases where patients with impending liver failure and confirmed VOD on histology got a transjugular intrahepatic portosystemic stent shunt, a TIPS, and it often resulted in improved liver function.
So you're decompressing the portal system, treating it as a portal hypertensive crisis, not just liver failure.
That's the rationale. The literature really suggests TIPS should be on the table for patients with rapidly deteriorating function post-radioembo. Pharmacologically, for proven VOD, using steroids and defibrotide warrants urgent investigation, but it's still off-label in this setting.
So to bring this all together for you in the angio lab, this liver injury is a form of sinusoidal obstruction syndrome. It's driven by a combined chemo plus radiation.
Yep.
In planning, you have to aim safely below that 0.8 GBq threshold. You have to prioritize selective treatment, and you need to enforce that 2-month chemotherapy-free interval after salvage procedures.
That huge reduction in morbidity, from over 13% down to 2.2%, proves that modifying your protocol works.
So what does this all mean for the future?
Well, the reliability of these modified activity calculation protocols is now extremely high. We're very good at delivering the dose we plan. So the real challenge moves upstream. The provocative thought is this: what advancements in personalized pre-treatment risk modeling will get this complication rate to zero?
You mean integrating more than just dosimetry?
Exactly. Integrating the patient's entire chemotherapy history, the specific agents, the cumulative dose, the timing with precise dosimetry. Our safety margins are constantly being redefined by clinical evidence, but the next frontier is definitely predictive analytics.
That's it. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.